Hi everyone, I'm Dr. Anu and today we'll be learning about atrial septal defects. This is a very important acyanotic congenital heart disease that we encounter on our day-to-day practice in the pediatric OPDs, and this is most oftenly a incidentally detected heart disease. So parents, when they come to know that their child has a heart disease, they're really concerned. So in this module, we'll be learning about the clinical manifestation, the pathogenesis, the management and prognosis of acyanotic congenital heart disease in children. So let's get started. So atrial septal defect. So we'll be learning about the prevalence, the types, the clinical manifestation, the investigation and management of ASD. So if you want further videos on other congenital heart diseases, you can mention it in the comment section, and please do like if you like the video and if you find this useful, and follow my channel for more such videos. So coming to the prevalence. So ostium secundum ASD occurs as an isolated anomaly in nearly 3 to 10% of all the congenital heart disease. So the incidence of OS ASD among all the congenital heart diseases 3 to 10%, with female to male ratio of 2:1. So it is more common in female compared to male. And 30 to 50% of the ASDs are seen as a part of other cardiac defects. So coming to the types of ASD, the first and the most important is the ostium secundum ASD. So it's the most common type, seen as 50 to 70%, and it is present at the site of fossa ovalis with the left to right shunt. So here we see the ostium secundum ASD at the site of fossa ovalis. Then ostium primum ASD. So ostium primum ASD can be seen isolated in 15% of the cases, or it is seen as a part of endocardial cushion defect. Then comes the sinus venosus ASD. So this is seen at the site of superior or the inferior vena cava. So if it is near the superior vena cava, it is called superior sinus venosus defect, and if it is seen near the inferior vena cava, it is called the inferior sinus venosus defect, and it is located at the entry of either the SVC or the IVC. Then comes the coronary sinus ASD, which is an extremely rare form. This is the coronary sinus defect. So we have 4 types: ostium secundum ASD, ostium primum ASD, sinus venosus ASD, and coronary sinus ASD. So patent foramen ovale doesn't ordinarily produce an intracardiac shunt. So coming to the pathophysiology. So you know that, so if these are the 4 chambers of the heart, so ASD is present between the interatrial septa. So here is the location of atrial septal defect. We know that the systemic circulation's resistance is high and pulmonary circulation resistance is lower compared to systemic. So always the pressure in the left atria and left ventricle is way higher than the pressure in the right atria and the right ventricle. So when there is a defect, the blood will flow from higher pressure region to the lower pressure region through the ASD. So ASD will produce a left to right shunting in patient. So when this becomes more severe, what happens is that there will be RA enlargement because of the excessive blood that is flowing to the right atrium. So you will see an RA enlargement. So because of the RA enlargement, there will be blood that is overflowing through the tricuspid valve that will reach the right ventricle, causing an RV enlargement. So there will be RV enlargement. So because of excessive flow of blood in this RA and RV, there will be more flow of blood through the pulmonary arteries. So this will cause pulmonary artery hypertension. So the 3 consequences of this left to right shunt includes RA enlargement, RV enlargement, tricuspid regurgitation, and pulmonary artery hypertension. So you see blood flows from left atrium to the right atrium. There will be creation of left to right shunt. There will be volume overload in the right atrium and the right ventricle. There is increased blood in the pulmonary blood flow. There is elevation of the pulmonary artery pressure, and then finally this will lead to pulmonary vascular remodeling. So coming to the clinical manifestation, in history you see that these are mostly asymptomatic. So infants and children are actually asymptomatic. On physical examination, what you can here see is a widely split fixed S2 and a grade 3/6 ejection systolic murmur. So this fixed S2 is mainly because you know that S2 is made of A2, P2. So here what happens? The pulmonary flow is keeping on happening, whereas your A2 has already closed. So your aortic valve has closed, but your pulmonary valve has not closed because of the excessive blood that is flowing through the pulmonary artery. So because of this, P2 will be prolonged. So there is a definite gap between A2 P2. So you hear a fixed split S2. Then there's a grade 3/6 ejection systolic murmur. This ejection systolic murmur is the murmur that you hear from the pulmonary artery and not the atrial septal defect. So you will see that from the heart the pulmonary artery is rising. So because of the excessive flow of blood, there will be a stenosis or an occlusion kind of picture that is happening because of the excessive rush of blood that is going through the pulmonary artery. So because of this, there will be a murmur that is generated. Then you can hear a mid-diastolic murmur at the left lower sternal border due to tricuspid stenosis. So coming to the echocardiography findings, so you know that your right atrium and the right ventricle is enlarged. So there will be a right axis deviation of plus 90 to plus 180 degrees. There will be right ventricular hypertrophy. There will be right bundle branch block. This because of the enlargement, the conduction in the right side will be prolonged. So this is not because of a defect in the conduction system. This is because of the enlargement. There will be a right ventricular block, and there is an RSR pattern in the V1. So in the V1 lead, you can see an RSR pattern. So this is an RSR pattern which you can see in the V1, which is typical for atrial septal defect. Coming to the radiology, so we saw that because of the RARV enlargement, there is cardiomegaly, RARV is enlarged, prominent pulmonary artery, and increased pulmonary vascular markings because of the left to right shift. So you see cardiomegaly, increased pulmonary vascular markings, enlarged pulmonary artery, right atrium and right ventricular enlargement. So because there is only enlargement of the right ventricle, there is no upturning of the apex, there is only a cardiomegaly. Coming to the echo finding. 2D echo is a diagnostic of atrial septal defect. So you can see the position, size, the type of the defect, everything is identified. The signs of left to right shunt include RV and RA enlargement, dilated PA, increased velocity along the pulmonary valve. And M mode echo, that is a motion mode echo, will show an increase in the right ventricular dimension and paradoxical motion of the interventricular septum, which are signs of RV overload. So here you see between the RA and between the LA and RA, there is a gap. This is called the atrial septal defect. So blood will flow from left atrium to right atrium. So coming to the natural history of the disease. So the spontaneous closure rate is nearly 87%. So if a parent comes to you asking, doctor, my child has an ASD of 3 mm, my child is 2 months old, what do? You just reassure them because the chances of spontaneous closure is nearly 87%. And an ASD less than 3 mm diagnosed before 3 months has 100% spontaneous closure around 1.5 years of age. So you ask them to come for repeated follow-up. An ASD more than 8 mm will rarely close spontaneously, and spontaneous closure is not likely to occur after 4 years. So if ASD is detected after 4 years of age, it's highly unlikely that the ASD closes by itself. So if a large defect is left untreated, congestive cardiac failure and pulmonary hypertension will begin to develop, and rarely CCF will develop in infancy. With or without surgery, atrial arrhythmias may occur. Infective endocarditis doesn't usually occur in isolated ASD, and cerebrovascular accident due to a paradoxical embolism is a known thing, but it is a very rare complication of atrial septal defect. Coming to the management. So you know that because CCF is not actually a very common presentation in infancy and childhood, there is no role of diuretics upfront in children with ASD. all you do is a non-surgical closure if the ASD is large. If it is persisting below 4 years, you do a non-surgical closure. This is a catheter-mediated device closure, and the devices can be amplastar septal occluder or a Gore cardioform septal occluder. The criteria for device closure includes an OS ASD more than 5 mm, hemodynamically significant left to right shunt, QPQS ratio of more than 1.5:1, evidence of RV enlargement, and enough septal ring for septal placement. So if all these criteria are fulfilled, then you can use either a amplastar septal occluder or a Go cardioform septal occluder to close the ASD. Coming to the complications of device closure, so there can be early ECG abnormality. An amplastar device can cause late erosion of the aortic root. A thrombus can form in the right and the left atrium. There can be release of nickel from this device causing allergy. There can be device embolism, or rarely there can be new onset headache secondary to placement of the device. Coming to post device follow, you can give aspirin antiplatelet 3 to 5 mg per kg per day for 6 months. Post procedure, you look for residual atrial shunt, unobstructed flow of the pulmonary vein, coronary sinus, vena cava. So you look at all the great vessels, how they are flowing. You see how the blood is reaching the heart and how whether there is a residual shunt. At 1 year and 1 month follow, you find if the echoes are normal, then you keep a yearly follow. That will be enough. Coming to surgical closure, so if the device closure is not it cannot be done, or if it is contraindicated, you move to surgical closure. So the indication include a left to right shunt with a QPQS ratio of 1.5:1 or greater. That means nearly pulmonary hypertension has already set in, or congestive heart failure not responding to medical management. The surgery is performed in infancy itself, or when the device is contraindicated. The complication include post-operative arrhythmia and cerebrovascular accident. So thank you for listening to this video. So this detail about ASD is taken from Park's textbook of cardiology. If you want more videos on congenital heart disease from these textbooks, you can mention it in the comment section, and I'll be posting a video on VSD soon. So take a look at the video. It will be very useful for your clinical practice and also for your entrance exams. Thank you.